I'll get started. All right, welcome everyone to the Public Health and Psychology 2 division. We have 5 presentations in this division. At each of the end of the presentation, we'll take questions from the judges and then the audience. You may ask your questions through the chat or use the Zoom raise hand feature and then wait to be called on. Before we present and begin our presentations, we will have the judges briefly introduce themselves and mention their research field if they may. Actually, we can get started. So I will have Cassidy start us off.
Hello, I'm Cassidy Mccotty. I am a graduate student in public health, and I've been on a couple of research teams. I'm really interested in today's topics because I've been on a research team that focused on mental health in veterans, and I know we're kind of talking about that area today.
Awesome, thank you. And we'll hand it to Shelby.
Hi, I'm Shelby Rivers. I'm a 5th-year PhD graduate at Baylor in the field of psychology and neuroscience, and my research focuses on social support and motivated health behavior, so as well as psychological well-being. So I'm looking forward to hearing the presentations today as well.
Awesome, thank you, Shelby. And so now we'll start our presentations. Our first presentation is by Aiden Ifoma Veda from Baylor University. And so your group may be able to share your screen and begin when you're ready.
Good morning, everyone. My name is Aiden, and I'm here with Veda Ifoma from Baylor, and we're going to be talking about our research, just looking at the relationship between mental health and body composition on a college campus, primarily in college students. So to give you all a little bit of background, we were working on the Attachment to God study, which was looking for connections between physical health measures, mental health measures, and spiritual measures, particularly one's relationship with and feelings towards God. So for this sub-analysis, we decided to focus on mental health measures and physical health measures, because we know that previous studies have shown that body composition, particularly obesity and lean body mass, correlate with mental health disorders such as depression. So we focused on body mass index and percent body fat and looked at how that was related to mental health in our study. And so we used 2 different questionnaires to collect mental health data. We used the Hospital Anxiety and Depression Scale, and we used the RAND 36-item short form survey.
So the HADS questionnaire is comprised of 14 items that measure the occurrence and intensity of depression and anxiety. Specifically, 7 of the questions are linked with depression, and the other 7 questions are linked with anxiety. And in regards to scoring, the higher the score, the more severe instance of depression and or anxiety that person has. For the SF36 questionnaire, that is comprised of 36 items, and that assesses 8 different health concepts covering mental and physical health. Due to the fact that this study is covering mental health specifically, we focused on 4 of those health concepts, with those being overall mental health, vitality, social functioning, and role emotional. For this questionnaire, vitality refers to one's energy levels. Social functioning refers to the ability for one to interact with others, and role emotional refers to when emotional and personal problems interfere with a person's ability to carry out his or her roles in society. In regards to the scoring for this questionnaire, the higher the score, the better your health status is for that given concept.
While we were investigating this relationship, we also recognized that the interplay between mental health and body composition is complex, with external factors playing into their relationship. And so another layer of our analysis included looking at diet quality. We used the Healthy Eating Index to assess diet quality of our participants, while also looking at its relationship with stress using the college undergraduate stress scale, and looking at how those 2 factors may play into both the mental health problems that we've mentioned, such as anxiety and depression, but then also looking at how it relates to body composition. To do this, we had a comprehensive questionnaire that we sent out to participants for 3 semesters, fall 2018, spring 2019, and fall 2019. After we had collected all the questionnaires and participants, the total sample consisted of primarily college students, totaling 139 people with a mean age of 21.4. Additionally, 85% of our participants were female and 15% were male. As we've mentioned previously, the participants completed a DHQ3 diet questionnaire, which is a diet recall, and that's what we used for the healthy eating index, an in-body body scan, which is what we use for the body composition measures, the hospital anxiety depression scale, also called HADS, and the college undergraduate stress scale, and the RAND 36-item health survey. All of the results were analyzed using SPSS, and then we're moving on to the results.
So for the results, we completed Pearson correlations and linear regressions. So one of the things that we did was compare each of the health concepts previously mentioned with both percent body fat and with body mass index. There's an example to the right with graph 1 with comparing mental health versus PBF. And it was determined that there was a significant negative correlation between percent body fat and overall mental health, percent body fat and vitality, and percent body fat and role emotional. Additionally, it was determined that body mass index is significantly negatively correlated with overall mental health, vitality, and role emotional. So it should be noted that there was no significant relationship between either of the body composition measures and social functioning.
Graph number 2 shows HEI scores in depression. So along the x-axis is the HADS depression score, and along the y-axis is the total HEI score. Like Afo mentioned earlier, HEI score stands for Healthy Eating Index score. It is a number produced by the DHQ3 questionnaire. And so on that scale, there's 0 to 100. Higher scores represent better overall diet quality. So we found that depression was negatively correlated with HEI scores. And I'm also going to mention that there was no significant correlations between HEI scores and stress or anxiety. Graph 3 shows anxiety and percent body fat. So the HADS anxiety scores along the x-axis and the percent body fat is along the y-axis. We found that anxiety was positively correlated with percent body fat and body mass index, although the body mass index graph is not shown. For graph 4, we have BMI and depression. BMI is along the x-axis, depression is on the y-axis. And we found, again here, the body mass index is positively correlated with depression, and the percent body fat was also positively correlated with depression.
So for our concluding remarks, it was concluded that BMI and percent body fat were negatively correlated with composite mental health and the related health concepts. So this suggests that body composition can affect not only overall mental health, but also vitality and role emotional. And due to the fact that this was a correlational analysis, the opposite can be said where these mental health concepts may be impacting body composition measures.
For graph 2, we found that HEI score was negatively correlated with depression. So this could tell us that being depressed may be causing people to have different eating habits and different HEI scores, or the reverse of that again would be that HEI scores and eating differently may affect if a person has depression or not. We also found that depression and anxiety were positively correlated with body mass index and percent body fat. So this may indicate that body composition and physical appearance and how one views oneself, like self-image, may be causing impacts towards one's mental health, or that mental health may be causing people to behave differently, whether that be with diet and exercise, which may be contributing to body composition.
Throughout our study, we analyzed and looked at the limitations that our sample size had. Two of the biggest limitations that we found were that the distribution of our sexes within our sample population was not representative of Baylor's campus. As we've previously mentioned, 85% of participants were female, whereas on Baylor's campus, approximately 59 to 60% are female. Additionally, the racial demographic distribution of our sample is not representative of the general Baylor campus. Within our population sample that we used, we had approximately 61% white or Caucasian, and for example, 7.9% Hispanic, versus at Baylor's University's campus in general, there's about a 63 to 64% white population and 14% Hispanic population. And so our results, while significant, may be limited in representing the broader community of Baylor, both in its sex and its ethnic background. After looking at all the results, there are some implications of the relationships that we found, and we focused on kind of three main ones related to actionable implications. So first is looking at how fitness initiatives can be better tailored and accommodating for how the relationship between mental well-being and body composition and physical health may be related. And so fitness initiatives can better improve their physical well-being by also incorporating mental health and psychological well-being factors and interventions. Conversely, mental health professionals can also coordinate with fitness and health and other fitness professionals to provide better solutions for mental health problems that incorporate physical well-being, physical health, and dietary patterns, because it is a complex relationship. And overall, understanding that the link between body composition and mental well-being can be mediated or also affected by our diet quality can be further incorporated into other initiatives, both in the healthcare field, public health, and on college campuses in various ways to help decrease the amount of mental illnesses that we're experiencing and better be able to handle college stress.
So considering the limitations that IFOMA elaborated on in our study, we hope that other studies can build on the significant relationships that we found and apply it to a more diverse and generalizable sample population. Additionally, we hope that more connections between other physical health, dietary, and mental health components can be made. Currently, we are also investigating the relationship between mental health and spiritual measures, such as one's attachment to God or closeness to God. And we're hoping that these efforts would all work together so that way universities can create a more comprehensive and holistic approach to improving students' well-being while on campus.
Thank you. Are there any questions?
All right, thank you so much, presenters. First, we'll hand off the question time to our judges. So judges, please feel free to ask any and all questions you may have for presenters.
Great presentation. I really enjoyed it, and it's interesting work. I did have a few questions. I can start off with one and I can pass off. My first question was, I know that you mentioned that you looked at that social functioning subscale of the SF-36 and that it wasn't associated with the body mass index and body composition measures. Did you look at it in relation to the healthy eating? Because there is a lot of research suggesting that our social relationships are intertwined with our eating behaviors. So I was interested in that.
Yes, I can answer that question. So we have not yet completed analysis for the HEI score in relation to social functioning specifically. We did do an analysis between HEI score and overall mental health. And from that analysis, there was not a significant relationship, but we do acknowledge that looking at the other health concepts such as social functioning would be something that we look at in the future.
Great, thank you.
All right, I have a question as well. So I guess to clarify with your research subjects, I saw that you collected over 3 semesters. Are these all individual people or did you follow them throughout 3 semesters?
Individual semesters. So the participants, we have this questionnaire opened for 3 semesters and we only collected it once for each participant.
Is there a particular reason why you opted with, I guess, a singular data point versus following a certain group over time?
This was an exploratory study, and so that was the format that we decided to take, but we are currently doing an investigation comparing the results that we received over those semesters in relation to right now during COVID and looking at how COVID may have altered some of these questionnaire results that we're getting. And so it has now become a kind of comparison between the 2 groups over time.
Thank you. Shelby, do you have another question?
Yes, so one of my other questions was about, I know you mentioned this as a limitation that it was 85% female, and I'd just love to get your input on what you think what kind of effect that might have for the results, and if you could collect a bigger sample and split up by sex or gender, what you might expect to find.
I can take this one. Personally, I think that probably the HEI scores were a little different as far as there probably was difference in reporting like diet. I think the females may be more focused on that sometimes, so they might have better results with that. I also think that I'm not sure what like differences we would see, but I definitely think that we really can't say anything like definitively like from this study just because of that differing sample size. So we would want to reproduce this with more even samples so we could see what differences there are.
Great, thank you.
Awesome. Thank you, everyone. We're a little bit short on time, so we'll keep the ball rolling. But if you have any questions, you can also feel free to put in the chat as well. So judges, do you need any more time to finish or any feedbacks or anything? Okay, perfect. So our next presentation is by Payson, Abel, Sarah, and Akshat from Baylor University. And when you guys are ready, you can feel free to share your screen.
All right, so our study is on moral injury during the COVID-19 pandemic. We used a Delphi model study to analyze family medicine residents across multiple sites. We'll go a little more in depth into what the Delphi model looks like and these sites that we looked at across our study. And so here's kind of the table of contents that we're going to go over real quick. I'll be starting with the background. So what exactly is moral injury? In beginning this project, we were very intensive in our looking at literature reviews. The topic itself has not been significantly studied, at least underneath the name of moral injury. So you'll notice a lot of these reference dates are within the pandemic timeline. It's become a more relevant issue, and so a lot of literature has been popping up about it. But we found that the most comprehensive, definition for moral injury is the one listed here. It refers to the profound psychological distress which results from the actions or inactions which violate one's moral or ethical code, and it may also result from others' actions or inactions. And so in this background, I just wanted to provide you with just some key insights of the literature review. It's definitely not comprehensive, but these are the kind of the ones I wanted to highlight, especially in terms of this presentation. So moral injury is one of the many factors that are linked to an increase in physician burnout. That was kind of one of their main threads that we followed, especially in going back in literature that was predating COVID. So you kind of notice the date difference in some of these. But moral injury has a significant impact in like the burnout rate of physicians and residents. So that was one of our main threads that we picked up on. In light of the pandemic, healthcare workers also have been exhibiting increased, anxiety levels, depression, insomnia, and distress. Lai et al. Is just a study I believe came out of China. They ran a bunch of different psychological examinations and found like these had spikes in healthcare workers. Most likely, understandably, due to intensive care that was required during the COVID pandemic. Residents in particular are at a higher risk of burnout due to moral injury, given the circumstances of their educational career and just entering the healthcare field. Everything is bright and fresh. So things are a lot more intensive in this respect. So we're analyzing that family medicine residents specifically. And then as far as what we framed our study, we determined that a need existed on how to identify the effects of the pandemic in bringing moral injury upon family medicine residents. By using the Delphi model as a guide, we identify first key themes across multiple responses from different sites that we'll go into more detail in a minute. And from these responses, we're trying to identify themes across them that they're reporting as being morally injurious to them. And we'll get to the next slide.
All right, next I will talk about what we have done so far, starting with just how we set up our Delphi survey model. So we first of all asked and sent these surveys to 4 different locations across the US, one being the Waco Family Health Center here and their family medicine program. And then we are working with a medical student at Stanford. So we connected with the Stanford O'Connor Family Medicine residency. And then we also sent it to the University of South Alabama Family Medicine Residency and the Western Michigan University Family Medicine Residency. So very geographically spread out. And we sent for the first round of our Delphi survey, the exact same survey to all 4 sites. So basically the Delphi model that we use is you ask a selection of experts in a topic questions and try to reach a consensus. So our group of experts that we focused on obviously was family medicine residents. And we started off with 1 round with pretty open-ended and safety net type of questions that included things that we found in the literature that we believed that the residents would have encountered. And then we based the 2 following rounds on those previous responses. So for the survey 1 components, we first of all had 2 objectives of this study. One was find the risk factors for moral injury and what could be causing it. And 2, find the barriers that may be keeping these residents from getting help for their moral injury. So our 4 questions that we included in survey 1 were qualifiers, some open-ended questions, some exploratory questions that were on a 5-point Likert scale, and demographics, just so we could see if there were any trends at the end of the data. So our qualifiers, of course, we did informed consent. So at the beginning of the survey, there was an explanation of what it would consist of and the risks and benefits. The risks basically being that maybe writing about some things that have happened might be upsetting, and the benefits being we could give information to the residency site to see if they could improve anything that's been a problem. And so, you know, they had to agree with the survey, and then they obviously had to be a family medicine resident at their respective site during the COVID-19 pandemic. And you'll see on the right, that is an example of our open-ended questions. So that question says, since the beginning of the COVID-19 pandemic, did you see, participate in, or were the target of activities that violated your personal moral values? And if they did experience that, they had a open-ended text box where they could explain. And if not, they would put no. And that's how we gathered a lot of our basic information. We also did some exploratory questions, which will be on the following slide. And then the demographics that we did request at the end of the survey were their age, their sex, their year in residency, which would be their 1st, 2nd, or 3rd year, and ethnicity and religious affiliation. And this is the exploratory question that we used for the risk factors. We also had a similar one for the barriers for help. Basically, all of the things you see in the left column are things that we commonly found in the literature that cause moral injury. And we put it on a 5-point Likert scale here so they could rate how much it affected them. And we chose to do a 5-point scale so that there would be an exact middle for an average, just to find ease of consensus. And so, yes, that's our survey 1.
After we've done survey 1, we were able to do a thematic analysis, and we started off individually working on our analysis using inductive coding. As Sarah said, we started off with broad questions and slowly working them down. Our initial aspect was to do initial coding, kind of taking every word that we saw and putting a theme behind it, trying to give some kind of meaning behind it. Then we would do line by line coding, going through each line and trying to get a general theme going for each line, trying to make sure that each one get more overlap between them. Then we would do categorization, see if there was even more overlap between them, get bigger, broader themes. And then we would do theme determination, really honing in on our themes and really determining it. And then we would get together as a group and do universal themes that we would see between our respective sites, as well as distinct themes that we would see for each individual site, which we will see in this slide right here. As you can see, the ones that are similar colored were themes that we saw that the sites had in common. The wordings might have been different, but the overall theme was the same. And then the ones that are not colored were the ones that we saw were distinct to each site. And then what we did next was to create our survey 2 using the themes that we analyzed from our thematic analysis, creating a distinctive survey for each site. So then we implemented these themes using both a Likert scale and exploratory questionnaires. So as you can see in the picture to the right, they would have a Likert scale, and then they had an opportunity to fill in the open-ended aspect of their question. And this analysis will eventually help us hone in our questions for survey 3.
So as we completed survey 2, we use a filter system to get to more specific areas. So now this is the last survey in our Delphi model. So again, we use the same process for creation of the survey using Qualtrics. And here we wanted a stronger sense of prevalent barriers amongst these residents to be identified for each site. And through the survey, at the completion of that and at the responses, we will conduct a thematic analysis. So our goal is to find a consensus of our collected data for final interpretation for each site. And this you'll see in our future goals. So this is where we're going. This will be our future plans from today onwards. So through the accumulation of the data we have collected, and after we get results for survey 2 and 3, a consensus will be formed about the prominent factors of moral injury that we see. And this will be individualized to each site through our Delphi model. So this data will be presented to each residency program after, so with insight on how they can address the issue of moral injury. And through this, each residency site will implement these, whatever we have addressed, to form a better environment for their residents to reduce burnout and moral injury, especially going forward. And then a further step that might be taken could be in regards to geographical trends. So as Sarah mentioned beforehand, most of our sites were spread out across the US. So in California, here in Texas, Washington. So you can see that these geographical trends could form a variety of influences on moral injury that could not be considered in a more broader spectrum through the surveys we have created. So a future step could be focusing more on geographical trends and providing more specific and insightful feedback on how their programs can be better for the future in terms of where exactly they are.
And real quick, at the beginning of the presentation too, you saw that we had a great selection of resources and people that were able to help us. We wanted to say a special thank you to the California Academy of Family Physicians. They actually approved a application that we had for one of their grants for $2,500. So we just have a little bit about their organization. They're solely dedicated to advancing the specialty of family medicine in their state. And the funding that we received is utilized in the study primarily for the incentivization of participants. Since we rely so heavily on those questionnaires, we really want to keep response rates consistent and high. And so we incentivize it through that grant. I think we can move to questions.
Thank you so much, presenters. Because we're a little bit short on time, we'll have only judges ask questions for now. And if presenters or audience members, have questions, feel free to put them in the chat.
Okay. Big identified within your results.
I'm sorry, you kind of cut out there. What was the question?
Oh, what specific themes you found within like your results section?
Yeah, if you want to go back to that Excel spreadsheet. Yeah, so like we said here, we have like these, we basically like color coded it through our different coding methods and the recommendations made through the literature review. And so these themes are being grouped primarily. These were the first survey 1 results. So for the Delphi model, the first goal of the survey 1 is to get themes to kind of narrow down your next set of questions. And so you can see that we have like in-cut access to PPE. So that's kind of like that pinkish color as one theme. So that was the thing identified across all the sites was PPE. The lack of it was, causing them moral injury. It was making their job, morally injurious. So that'd be one theme, for example. And most of the themes are also available like in the survey 2 questionnaire. It explains a little more about that. So a lot of it is on the Qualtrics that we have set up for each of the sites.
Try to clear list maybe if you like. One was residents had to prioritize others' health instead of their own, and through that they just increase their risk of exposure. Another one is they had the inability to gather with friends and family because they would be exposing them. Another one would be they had new responsibilities and expectations coming straight out of medical school and that is with minimal training. So during this COVID pandemic, that caused to increase burnout. The doctor-patient relationship was limited due to isolation in these sites for more protection, and there's an overall increased workload compared to if this was happening in a normal environment.
Great, thank you.
If we have time for one more quick question, just kind of as a follow-up to Cassidy's, a lot of these factors seem to be things that maybe have a limited ability to change during an emergency situation like this. Were there any themes that you identified that could be potential mechanisms for intervention to prevent these circumstances, to prevent moral injury?
Yeah, we did find a few that could be worked on, specifically privacy issues. There was one subject that said that there was a lack of privacy with telemedicine that they could improve on. Also, just the morale between residents. There were some people that were more cynical, or, people that had differing views around it. And also there were just inconsistent protocols. And so the residency site would be able to, try and crack down on those protocols so that there weren't conflicting opinions and things like that.
And also, since this is survey one, as we go through with more surveys, we get more specified to each site, to where how each site works, what specific practices they follow that could improve. So as we get more specified to them, we will provide specific insight on how to improve and what they can do following our complete study.
Excellent, thank you.
Awesome. Thank you very much, presenters. Our next presentation is by Shawray and Khushbu from the University of Houston. So feel free to start whenever you're ready. Are you able to possibly increase your volume? I think the output is a little bit softer. It's still about the same, yeah. It feels a little bit muffled. I'm not sure. Let's see, Khushbu, is it all right if we go with the next? Oh, is everything set up? Okay, we'll have you start right after the next presenter. No worries at all. Thank you very much. Awesome. So the next presentation will be by Savannah from SMU. And so whenever you're ready, Savannah, you can go ahead and screen share.
Okay, can you guys see my slides?
Yes, perfect.
Okay, hi everyone. My name is Savannah Osner and I'm an undergraduate senior at Southern Methodist University. I have had the privilege to work with Dr. Tabak and his social and clinical neuroscience lab on my project titled Distinguishing Errors in Mentalizing Associated with Social Anxiety Symptoms and Traits Related to Autism. So as social beings, we spend a majority of our day interacting with other people. Not only do we talk to and work with others, but we also think about others, wondering what they are thinking, while simultaneously interpreting their intentions, their desires, and their beliefs. The social cognitive ability to identify and reason about the mental states of other people is referred to as theory of mind or mentalization, and is seen as critical for social interactions. However, deficits in social cognition, especially in theory of mind or mentalizing ability, can lead to difficulty evaluating or understanding the thoughts, the intentions, or the actions of other people. So social anxiety is marked by a fear of negative evaluation, resulting in difficulty navigating social situations. Furthermore, the distress experienced in social situations is often manifested as the avoidance of those situations and can lead to increased vigilance and hyperarousal. This may be partially attributed to a deficit in theory of mind. Difficulty understanding the mental states of others may stem from an overinterpretation of others' thoughts and intentions, also known as hypermentalization. In other words, people with social anxiety are more likely to believe others are feeling more intense emotions and attribute greater meaning to their thoughts and intentions. Impairment in social cognition, including theory of mind, is also a well-known feature of autism spectrum disorder and is also seen in subclinical populations among individuals with traits related to autism. It is thought that their ability to infer the mental states of others is either absent or very limited, as they can show difficulty in understanding the perspectives of others. Therefore, rather than errors in social cognitive ability resulting from hypermentalization, these errors have been related to a lack of interpretation of others' emotions, thoughts, and intentions, or hypomentalization. While this type of impairment seems to directly oppose that of social anxiety symptoms, there is also evidence that the core symptoms of social anxiety, of autism are anxiety driven. Indeed, autism spectrum disorders and social anxiety disorder are often comorbid, and both are characterized by social anxiety, avoidance of social situations, lack of social motivation, poor social skills, and a preference for being alone. This frequent comorbidity, along with the overlap of symptomology between traits related to autism and social anxiety symptoms, such as apprehension about social situations, makes it important to disentangle the specific differences in mentalizing between the two. Therefore, in this present study, we set out to examine how traits related to autism and social anxiety symptoms uniquely predict social cognitive ability in the form of mentalizing by including measures of both in the same model. So our study consisted of 332 undergraduate students at SMU. Our population was mostly female, with 70.9% female, and our average age was 19.5. Our study was a 3-part study when we started data collection in spring of 2019. So this has been going on for multiple semesters. Before COVID, people came into the lab and they took a Qualtrics survey in the first study, or the first part of the study, and the second and the third part were different behavioral measures along with more surveys. So for our study, for this study's purposes, we used the autism quotient to examine traits related to autism. And then we use a composite social anxiety score to look at social anxiety. So the composite social anxiety score was actually a standardized average of 3 different scales. We used the social phobia scale, the social interaction anxiety scale, and the Leibowitz social anxiety scale. We also looked at several covariates such as age, gender, depression symptoms using the mood and anxiety questionnaire, general depression subscale, and then the Toronto Alexithymia scale to look at alexithymia, which is your ability to interpret the emotions of yourself and other people. Our behavioral task for this study was the movie for the assessment of social cognition, or we also call it the mask. And the mask consists of an ecologically valid 15-minute video about 2 men and 2 women who are attending a dinner party. And it depicts different social situations that include misunderstandings, irony, flirting, insults, and the use of body language that would be typical of normal social interactions that people experience in their everyday lives. Participants answer a total of 48 multiple choice questions that include 6 control questions, and the questions require them to make inferences about what the characters are thinking, feeling, or intending at various time points. As you can see, this is an example of one of the questions. It asks, "What is Sandra feeling?" And then the different response options help distinguish between the different types of theory of mind errors. And this question, excessive theory of mind or hypermentalizing, is the option that says she exasperated about Michael coming on too strong. The less theory of mind or hypomentalizing option is that her hair does not look that nice. And then there's a no theory of mind option that basically is when the participant uses a concrete or factual explanation that doesn't require any mental insight. And so in this question, that would be her hair does not look that nice. And the less theory of mind is that she is pleased about his compliment. The accurate answer in this situation would be that she is flattered, but somewhat taken by surprise. So the task records how many times they answer accurately and which errors they use when they do not answer accurately. Based on previous findings, we hypothesized that both symptoms of social anxiety and traits related to autism would be negatively associated with theory of mind or accuracy on the mask, with traits related to autism showing a stronger negative association. We further predicted that social anxiety symptoms would be positively related with hypermentalizing errors, while traits related to autism would be positively associated with hypomentalizing errors. However, contrary to our hypotheses, we found no significant association between social anxiety symptoms and theory of mind accuracy. However, we did find a marginally significant negative association between traits related to autism and theory of mind accuracy on the mask. Additionally, social anxiety was not significantly associated with hypermentalizing, and traits related to autism was not significantly associated with hypomentalizing errors. While we did find a marginally significant negative association between traits related to autism and theory of mind accuracy as expected, our other results were surprising and do conflict with previous research and already accessible literature. This could be because of our sample being different in terms that we looked at a non-clinical undergraduate sample. Further, our findings may differ from previous studies as we looked at a non-clinical we included a lot of covariates that made our study very conservative, and we explored whether social anxiety and traits related to autism individually predicted accuracy. As there's a lot of overlap between the two, and we wanted to look at the effects over and above other things that may be at play, such as depression and alexithymia. In our exploratory analyses, we discovered that analyzing the data the way the other previous studies have, yields significant results. However, when accounting for the effects of depressive symptoms and alexithymia, the significance is negated. Therefore, in our study, we found that social anxiety symptoms do not predict hypermentalizing errors over and above other covariates such as depression and alexithymia. We also plan to continue looking at our exploratory analyses, which include looking at whether the type of stimuli, whether the question asks about feelings and emotions or thoughts and intentions, influences the type of mentalizing error to see whether social anxiety plays a role in these types of errors committed on specific question types, as previous work has shown that those with social anxiety disorders are less accurate in identifying and reasoning about thoughts and intentions than they are about emotions. Further research should also continue to examine the overlap in symptomology between traits related to autism and social anxiety symptoms and their individual differences in theory of mind or mentalizing ability. Because of their frequent comorbidity and overlap in symptoms, we must be able to tease out their individual effects on social cognitive functioning over and above those effects of other constructs. Further, future research needs to examine whether social anxiety effects occur only in a self-referential context when you're thinking about yourself in that situation, or when you're thinking about other people and what they may be interpreting, or if these effects that we do find result from a negative interpretation bias. Thank you all so much for your time and for listening to my presentation today. And I wanted to quickly say a special thank you to Dr. Tabak, his grad students, Tala and Cece, and then the rest of the social and clinical neuroscience lab at SMU for all of their help and support. And I would love to answer any questions you guys may have.
Thank you so much, Savannah. Judges, feel free to take this time to ask any questions.
Hi, great presentation. You answered one of my questions, which was about whether you tested without covariates without me even having to ask it. But I did have a question about the rationale for controlling for alexithymia. I'm not as familiar with social anxiety, but I know it has been linked to autism spectrum disorder symptoms. So it seemed an interesting choice to control for something that we might normally put under the umbrella of autism spectrum, like presentation.
Yes, that's actually a really good question. Alexithymia is kind of, for all of you guys, it's the ability to interpret your own emotions and the emotions of others. There have been studies that have linked alexithymia to social anxiety as well. So we wanted to look at the traits that are specific to just social anxiety or just autism. So we wanted to control for any overlap that may have been between the two. And then there are also studies that, there was a previous study that linked alexithymia. They show that it changes the results on the mask for those with autism as well. So we just wanted to be very conservative in our analyses and make sure that we looked at it as specifically as possible. I hope that answered your question.
Excellent, thanks.
Awesome.
Can you hear me? Sorry.
Yes.
Okay, great. I know you discussed that your results aren't consistent with previous research. So can you just reiterate, I think, maybe the place that your study has and what you would expect other researchers to do based off what you found in your study?
Yes. So our study, unlike other researchers, we included those extra covariates that other people have not included. There's a lot of discontinuity among the research of what they have found in social anxiety. The ones that include depression don't find anything, and the ones that don't include depression do find stuff. So we included both depression and alexithymia. Some studies find gender effects and some don't. I think a large part of it depends on your sample. But in general, we took a very conservative approach by including all of these covariates, whereas other studies have just looked at social anxiety or traits related to autism. So we are hypothesizing that we found different results because of our stringent look at it, our stringent approach. But we suggest that other studies look at it both with the covariates or without, to try and disentangle more of what's happening underneath, because there is such a complex interplay of so many different facets within these two constructs. I hope that helped elucidate some of your question.
Yes, thank you.
Awesome. Thank you so much again, Savannah, and to all the judges. We'll go ahead and get ready for the next presentation. So let's see, Share and Kushbu, is everything working fine now?
Yeah, it should be. Can you hear us now?
Perfect, yes.
Okay. All right, great.
Awesome. So just to give a quick introduction, Share and Kushbu are from the University of Houston. And so whenever you guys are ready, feel free to screen share.
Okay. All right, can you guys see the presentation now? Perfect. Okay.
Okay, so good morning, everyone. My name is Kushbu Shukla, and I'm a sophomore biology major at U of H.
All right, good morning. My name is Shar Kashyap, and I'm a senior biomedical engineering major at the University of Houston. And recently, Kushbu and I have conducted a study on the effects of COVID-19 pandemic on mental health, and those results are what we are going to be sharing with you all today. So COVID, as we all know it, has taken our lives over for almost over a year now, and it's completely changed our day-to-day routines. Now, from working at home and studying at home and having to do curbside pickups, having layoffs, lack of jobs, mask mandates, lockdowns, quarantines, all those things, COVID has put us through tough times a lot this whole past year. So all of these events are known as stressors, which are any experience or stimulus that causes stress on an individual, which takes a severe toll on mental health. And throughout the pandemic, there have been some studies which analyze the extent of this stress, but in our study, we wish to characterize the various factors and patterns that were observed.
So when the pandemic first started in early 2020, it was honestly not as mentally exhausting, right? In March, we got an extended spring break. We thought we'd be back on campus in a few weeks, extra time to spend with family, and it was pretty much as good as it gets. But as weeks became months and months became a year, Shari and I were both victims to the hidden side of the pandemic. Yes, COVID is a deadly respiratory illness, but no one really mentions that it's just as deadly of a mental condition that we've been facing for so long. We ourselves felt isolation and anxiety and wondered if this was widespread or is it just us? And so that's why we decided to work together as a team to create a study to investigate the mental toll the pandemic had taken. We were especially interested in looking for patterns in groups of people based on ethnicity and to see what percentage of the people felt certain symptoms related to depression and anxiety. So how did we do this? We used an anonymous self-reporting survey, which was sent out to individuals of all ages throughout the United States and internationally, and we had a total participant, 750 total participants. They completed the survey through Google Forms without any requirements to answer every question, and no personally identifiable information was collected. Our survey was based upon established tests, such as a 4-item patient health questionnaire, a 2-item depression scale, a 9-item depressive disorder scale, and a 7-item anxiety scale. The QR code to our survey is provided here, so if anyone would like to take a look, feel free, and it will also be available at the end of our presentation. So these are some of the questions that were based on the established PHQ and generalized anxiety disorder test, the survey tests. So the first one, in our survey, we asked the participants to overall kind of give a gist of how the pandemic has impacted their mental health, where 10 is very positively and 1 is negatively, and then 5 is neutral. And then the second question was asking the participants about specific challenges or feelings that they have been feeling since the pandemic has grown. And it was a select all that apply question. So the specific measures of interest for our study were focused on previous diagnosis of mental illness, because that can really play a role in whether or not it increased or decreased during the pandemic, as well as pre-pandemic hours spent outside the home, current hours spent outside the home, pre-pandemic stress levels versus current stress levels, challenges faced during the pandemic, and the self-reported impact of COVID on mental health. And those last 2 points were the questions on the previous slide.
Okay, so one of our key statistics that we looked at was depression and anxiety symptoms. We found that 64% of US respondents reported having symptoms of depression and or anxiety. And so comparing this with a study from June of 2020, which was 3 months into the pandemic, there has been a 33% increase. Back in June, there was only 31% of people reporting symptoms of depression and or anxiety. And we also examined the relationship between the different ethnicities, and we found that Asian respondents tended to have the lowest reported percentage of depression and anxiety symptoms, which was at 54.6%, and Caucasians and Hispanics had the highest percentage at 71.2% and 71%. This last section that we have here is other. Since we didn't have significant amounts of data for the other ethnicities, we grouped all of the ethnicities that weren't in these 4 categories into one section.
We also had a question on our survey referring to suicidal thoughts, and we found that 10.1% of US respondents reported suicidal thoughts since the pandemic. For comparison purposes, pre-pandemic levels were at 4.5%. In May 2020, about 2 months after the pandemic had officially begun, that number had risen to 8.4%. Our international respondents reported a lower percentage of suicidal thoughts at 7%. Canadian respondents had 15.4% of the people reporting suicidal thoughts, which is a 3.6% increase from pre-pandemic levels in Canada.
Okay, we also had 2 questions in our survey related to stress. So one question was to ask about stress levels before the pandemic, and another question was to ask about stress levels since the pandemic has begun. And so the pre-pandemic question basically served to establish a baseline of stress levels, and that was before the pandemic for the different respondents that we had. The 3 largest categories for that question were neutral, stressed, and then calm. When we got to the pandemic question, we saw a complete flip, where the top 3 categories ended up being stressed, very stressed, and neutral. And we found that 53.6% of the US respondents that reported being either calm or very calm prior to the pandemic actually reported being either stressed or very stressed now. And this alluvial diagram right here shows all the different movements between pre-pandemic stress reporting levels and current stress levels.
So the last question on our survey was to collect self-reported data on how people perceive their mental health since the pandemic has begun. We found that the vast majority of respondents reported having a negative impact both in the United States and internationally, at 53.73% in the United States and 50% internationally. Surprisingly, we found that roughly a third of US respondents reported COVID actually had a positive impact on their mental health, and that number was even larger internationally at 38.1%. This was not an expected result, but we believe that this could be a result of mental health becoming destigmatized, and we think this is a good foundation for future research.
So in conclusion, we've seen various mental health aspects have been affected by the pandemic. A comprehension of the change in mental health throughout the pandemic in comparison to pre-pandemic times has significant implications on both public health and human psychology. So the way that our data has shown significant increases, not only from pre-pandemic levels, but also from data from May and November throughout different time periods in the pandemic, we believe that this pandemic is going to have a prolonged impact on mental health. And we believe that that's why it's very important to continue doing studies on this, because we don't know just how long of an impact this is going to have. The two main limitations that we had in our study setup was the sample size and the snowball effect. So our sample size was only 750 respondents, which is a small number when the analysis is met for nationwide results. And the majority of our respondents were from Texas and the United States, which also makes the validity of the Canadian and our international data less concrete. That's why most of our actual analysis is focused on the United States data, because that is the more concrete data. Additionally, the snowball effect is because the surveys were meant to be anonymous, so we distributed them through various channels of social media, and then those were dispersed throughout families and friends randomly, and we had no way of tracking who it was because we wanted to keep this anonymous. But this also led to what could have led to what is known as the snowball effect, where a large number of data is collected through the different relatives of people who received the survey. And so that could make the data less representative of the whole population, since it is possible that these results were localized to certain groups just innately.
So it's possible that as the pandemic span increases, isolation, financial pressure, and other such variables could be the root cause of anxiety and depression related symptoms. But future studies are needed to confirm these claims. As well, future studies can analyze how our data has evolved after vaccination, and that can be compared to the data from pre-pandemic times. It is clear that COVID has had an impact on mental health, even as the limitations on society have started to go down. This is why we believe that continued studies are necessary to evaluate just how much of an impact this pandemic has had on society's mental health in the long run.
We wanted to give a special thanks to Dr. Danielle Price and the mentors at the Neuroscience Establishment for their guidance throughout the various steps of our project. And thank you for your time. Here's a survey link if anybody wants to open the QR code to read it, and feel free to ask any questions at this time.
Thank you.
Thank you.
Thank you so much, presenters. I will now hand it off to the judges.
I have a quick question. Great work. I had a question about the stress items about pre-pandemic stress. Do you think that there are any biases as far as retrospective reporting that could have affected these results?
Yes, yes, that's one thing that we were hoping to account for, and we're still conducting our data analysis. So we're also looking for other surveys and other reports, research articles that have been published pre-pandemic times to see if comparing that data to the data that we collected, if that is valid. When we compared that for our suicidal thoughts data, we found that our data did correlate, but we're still working on processing through all the other aspects of our data.
Awesome. Any more questions? Okay, sounds good.
Oh, sorry. So I guess a quick question about the one survey that you showed us. I saw that there were 10 points, and I was wondering, was is that a tested survey, or did you decide on that? And if so, was there like significance between the selections of like a 7 or an 8? Because sometimes when there's, I feel like a lot of options, the significance of a specific number kind of loses, like it just loses some of the.
Are you talking about the scale question?
Yes.
Yeah, so that question was based off of
Mhm.
another patient health questionnaire that we had found previously established, and so is the other question that's posted on this slide. We did consider the 1 through 10. So what we were trying to establish it as was 5 as neutral. And when we were doing our data analysis, we did different measurements between if we only measured 1 through 3 and 7 through 10 as as very negative or very positive. And we also compared it as 1 through 4 and 6 through 10. And the results were pretty similar. So we assumed that it wasn't making too much of a difference.
Awesome, thank you very much. So we'll get the ball rolling and we'll have our final presenter today. Thank you, presenters. Our final presentation is from Rachel, and she is from Baylor University. So Rachel, if you're free or you're ready, feel free to start.
Hey, hi everyone. My name is Rachel Mason, and I'm here to present my research on a topic that I am very passionate about. I did some research on the stigmas of mental health care and moral injury in the military. I worked with Dr. Sheila Frankfurt, Dr. Sarah Dolan, and Dr. Lars Zambrano Vasquez, so I'm very grateful for all of their help. The two primary objectives for my research were to understand how stigma affects individual military members in their abilities to seek mental health care. And then I wanted to predict if stigma against moral injury in particular would be a barrier to care for service members seeking care for that particular subset of mental health. And the reason I did this is because I feel that stigma still persists as a significant barrier to mental health care in the military, despite kind of their efforts to try and break that down and reduce that barrier to care. And because of that, service members may seek care from non-traditional sources like military chaplains or just talking to friends and family. And so, my intent was to learn a little bit more about this and then also to predict how they would respond to moral injury, because that is a very unique diagnosis. It's it has a lot of moral implications about service members and their buddies and their battle buddies and their friends, as well as the military in general. And so I was wondering if there is some if there's some stigma associated with that particular diagnosis and whether or not that would affect their ability to seek care. To do this, I utilized what's called a rapid qualitative assessment, which was developed by Dr. Allison Hamilton, and that consisted of 15 to 45 minute semi-structured interviews where I asked 15 questions. Some examples of questions are listed. So like I would ask them on a scale of 1 to 5, how likely were you to seek mental health treatment at a base clinic or another healthcare provider, and things like that. I collected their data in a password protected file, and then that data was organized into major C's to identify patterns and gaps in knowledge. My study population came primarily from the Veterans of Baylor organization here at Baylor University on campus. Most of the veterans were young. They came from the Operation Enduring Freedom, Operation Iraqi Freedom eras of service, so 2001 and everything since then. However, most of the veterans were younger than that, coming from the last 5 to 10 years. Most of them were enlisted. They came from several branches, including the Navy, the Marine Corps, and the Army. And they were about 25 to 40 years old. Like I said before, I utilized a rapid qualitative assessment. You analyze qualitative data in domain response matrices. And as I said before, that allows you to look at your data, find your patterns, find your gaps, and so on. So what I found with relevance to what I was looking for is that the primary barrier to care for military members seeking mental health care is fear that it would damage their career in some way, form, or fashion. This is particularly, in some cases, this was just fear. In some cases, this is actually due to past experience of that happening. Additionally, not having support from leadership was a significant factor in whether or not they would seek care. And that also played into that career damage, because having more supportive leadership would mean less likelihood of damaging your career because you sought mental health care. As far as the chaplaincy goes, they did find that a chaplain was a bit more approachable than a traditional mental health source, but in general, they just weren't heavily utilized and they wouldn't be a good bridge to care. The chaplains were the only veteran who mentioned having any sort of relationship with the chaplain had kind of built one up as the chaplain made an effort to work with the unit and go out for drinks and things like that. But on the whole, they weren't heavily utilized, particularly like religious service members would be more likely to seek care from their local religious services, from their churches, and what have you. As far as moral injury goes, most of the veterans were very unfamiliar with the term. So this is still a very new term in the psychology community, and they really had never heard of it before. And so we can definitely work with education and dissemination to help make this term more widely used and available, so that veterans who need to seek care for this particular subset of mental health issues can do that. However, after having the diagnosis explained to them and discussing a little bit, most of them were very supportive of its use, particularly if it would provide more individualized care to other veterans. And that was a very prominent thought amongst all of the respondents. Additionally, some general findings I found that were outside of the scope of what I was looking for, but I still thought were very relevant and interesting things to note, were that all participants endorsed a strong resistance to seeking mental health care during their military careers. Again, the primary issue behind this was the career stigma, but just in general, none of their participants were interested in seeking mental health care as while they were on active duty. As far as after they'd gotten off of active duty, they were a bit more receptive. They felt a bit more support from their community, but it still wasn't it wasn't widely utilized. The other thing that I noticed is that mistrust in the military healthcare system as a whole was highly prevalent amongst all the respondents. And I think this is a very important thing to look into further, because if service members are not utilizing the DoD healthcare system for them, they're going to exacerbate any injuries they receive. They're not going to be able to get adequate healthcare for mental health care or physical health care. And so I think this is a link that needs to be investigated further. I expanded my literature research to include this aspect, and there's not a lot of research on this particular in this area, because the military doesn't do a whole lot of research on its own, and it's not, and it really isn't an issue that would concern the civilian researching world. And so I think this is an area where we need to see more research. And finally, I did notice that all of the veterans acknowledged the importance and the validity of mental health care, despite their reluctance to seek it on active duty. So I think this was a good positive finding that shows that we are making progress in this area. The idea of mental health care itself is not stigmatized in the military. It's just actually seeking care still is, again, primarily because of that career factor. So just to discuss these results a little bit, I think some ways that we can utilize this is number one, to continue trying to reduce career stigma in the military. Some ways we can do this is working with lower level leadership, like non-commissioned officers and company grade officers. Those lower level research or lower level leadership positions really set the tone in the military, and working with those groups to help reduce career stigma, I think, can be a very powerful force for veterans. Additionally, I think we should empower service members with their rights, and we should educate them on what can and can't happen to their career if they seek mental health care. That way, they feel well educated and knowledgeable on how the system works, how they can fight any unjust damage to their career, and feel empowered to seek mental health care because of that education. I think we need to work on increasing trust in the military healthcare system. I think we need to do a lot more research in that area, because the whole system is a very expensive, specialized program that we've set in place. They do a lot of really great work, but if this is a serious barrier to care to service members, then we need to address that so that they get the care that we need, and those resources are not going to raise, because military doctors do in fact do more than just prescribe aspirin and tell people to change their socks. They are well-trained physicians, fully licensed in the United States, and so we need to make sure that people are able to utilize them. We need to focus on individualizing healthcare within the DoD and the VA. Most of the service members acknowledge that they often felt like a number on an assembly line, coming from just the nature of the military and the nature of the VA. And so I think personalizing their care can be very powerful and help them get better care. And finally, I think we need to focus on individualization and moral injury study recruitment, since that was such a unique concern for them. That can be an area to increase numbers in these studies and help provide better care in the future. Some limitations of the study included, so my sample consisted primarily of veterans assessing how they felt while they were on active duty. So that is a kind of a retrogressive look at their thoughts. Additionally, there were no long-term service members. Most of the participants had served about 4 to 5 years. One had served 9 years, but there were no 15 to 20-year career members. And so their opinions would very likely differ from someone who spent a much shorter time in the military. Most of the participants were at least a year out of active duty, and so very young veterans are probably going to feel very differently from, say, a Vietnam era veteran. And finally, a single 45-minute interview definitely captures a lot of their thoughts and their opinions. However, it probably doesn't capture the full scale of it. And so just noting that this does only capture a picture of what they think on these topics. So I think some future directions where we can take this research is increasing the awareness of moral injury so that veterans can better seek care. Additionally, I think we should investigate how empowering and educating service members can reduce career stigma. I think we need to continue reducing all mental health stigma and all physical health stigma on active duty, increase trust in the military healthcare system, and continue improving PTSD and moral injury treatments for veterans in the future. These are some of my references, and this is all I have. Are there any questions?
Thank you so much, Rachel. I apologize for that green line. I'm not sure how that was there, but I tried taking it out. You can Google, but for some reason, it just I don't have controls for that. So I apologize.
No worries.
But if any of the judges want to ask any questions, feel free.
I just had kind of a clarification on the term. I wasn't familiar with the domain response matrix, and I was wondering if you could unpack that a little more and explain it for me.
Yeah, so basically what I did was each question that I asked kind of was designed to collect a specific kind of information. So that was the domain. And then the response was basically just what each participant said. Kind of this particular method for analyzing data wants you to keep as much of their response intact as possible, as much of that context as possible. And so I listed out each of the domains based on the question that were asked. And so that's kind of the the kind of data, the kind of response that I was looking for. And then each participant went on the other axis, and then I listed kind of their responses as much in context as possible, and then utilized that chart to see where the patterns in their responses were, where the kind of gaps in knowledge were, and to analyze their responsive qualitatively in that way.
Great, thank you.
So I guess, yeah, a clarification. So you mainly were sampling veterans, but this was asking about their time while serving?
Yes.
So do you know how many of the veterans were receiving care when you were, I guess, assessing them or asking them the questions?
So part of my protocol was that I was not going to ask any specific questions about their history seeking mental health care or not, although most of the veterans, I come from a very strong military background. I'm a brat, I'm an ROTC and that kind of thing. So they were very open with me as I'm kind of part of their community. And one did mention that they had sought mental health care while on active duty, but only at the very end of their career under a very special circumstance. Another one mentioned another instance of seeking mental health care under a required under a circumstance where the Army required him to seek care, but I did not ask any specific questions about their care other than what they volunteered for me.
Awesome. Thank you so much, Rachel. This concludes our Public Health and Psychology 2 division.